Let me start saying thank you so much for this kind invitation, and thank you to everyone to be here, taking your time to hear me. Well, the topic of the day is to optimizing stenting approach for better outcomes in lower limb CLI patients. When, why, and what? And I think this presentation will perfectly match the previous one and will continue inside of this very interesting discussion. The challenge about SFA and popliteal artery or the complex lower limb lesions, as the previous colleague said, what we found in most of the cases is calcified lesions that after pre-dilatation will finish in a dissection, subintimal outcomes. If we start to think about to oversize it, we can finally obtain a perforation with a high risk of embolization. In the other hand, if we don't manage in the proper way the vessel preparation, what we can obtain is an incomplete stent expansion after stenting. So vessel recoiling, dissection, and finally bad result. So the question is how we can manage it, improve the acute game, limit the flow limit in dissection, make acute success easier and quicker, improve the long-term outcomes, because when the acute result is not good, the long-term outcomes are not good, and conserve stable lumen over a long period of time. For sure, we have available multiple treatments and multiple devices, but let me say my personal opinion, not every device adapt or has indication for any type of lesions. What we can do is playable balloon angioplasty, drug-coated balloons, bare metal stent, drug-eluting stent, atherectomy, some special stent like mimetic technology, and we can also combine some special balloons. But what is the standard of care? As Dr. Mai said, the good vessel preparation is, in my mind, the first key factor to obtain an acceptable and a long-term good result. So prepare the vessel with less overstretch. It is very, very difficult when we have long calcified occlusions because it's very difficult to don't overstretch the arterial wall. But for sure, going step by step, increasing the diameter of the balloon step by step, allow us to do not overstretch too much the arterial wall. Preserve the native vessel with less metal burden if shortened stent segment is achieved. For sure, nobody wants to cover the collaterals, or nobody wants, when we discuss specifically about the common femoral, we don't want to jail the profunda, even if in many cases it's necessary, but we always try to preserve the native arteries. And good key factor talking about the vessel prep is the time of angioplasty. Prolonged inflation, at least 3 minutes, but in some cases we arrive even at 5 minutes, may assist the dissection healing and for sure may contribute to better lumen gain. As the previous speakers show, we must have in mind an algorithm because it's clear that we have multiple options and we have multiple lesions and multiple devices. So for easy lesions, leave nothing behind can be a solution. In most of the cases, it can be possible. Do a playable angioplasty, check if the result is acceptable, move forward with the DCB. As well, in the opposite side, the complex lesion in most of the cases could need some a combination of devices, some more interesting or more complex treatment. It means atherectomy in some cases in which the indication can be done. For sure, if we cross subintimally, it's many difficult. It's not sense, more than difficult, it's not sense to do an atherectomy. As well, if we have a long CTO with the calcium and high risk of embolization, maybe it's better to avoid atherectomy, but we can combine special balloons like scoring balloon, cutting balloons, chocolate balloon, and finally obtain the best lumen gain and move forward for stenting. And it could change between spot stenting if we have a focal dissections or focal lesions, or a full metal jacket in a long CTO. For sure, stent proved a good result as a standalone therapy. We know from more than 20 years ago that occlusive lesions, CTOs, perform better or give us better result in the long term after stenting compared to do not stent. But we have multiple data in the literature about the performance of the stent. For sure, today, discussing about the combination therapy in the complex lesions, we can also think about atherectomy or DCB or both. But finally, we realized that even in those cases, we could need, in some of those cases, we could need a stent because, for example, bailout stenting after atherectomy, even if it's not in a high percentage, there are a percentage around 5% that could need a bailout stenting or a provisional stenting after DCB use, because what happened is that we do a good pre-dilatation, we move forward with the DCB, and after DCB we realize we finally have a stenosis, a residual dissection. So at that moment, we will need a provisional stenting. So being back to the discussion, today we have Supera, we don't need another stent? Oh yeah, we absolutely need another stent. As the previous colleagues said, for example, the case of vessel prep, use of DCB at 5 millimeters or 6 millimeter, you don't have enough chance to post-dilate again for Supera. So this could be a perfect case in which we will need a standard nitrogen stent like Pulsar T3 from Biotronic. For sure, use adjunctive therapy to DCB or alternative drug-eluting stent. Calcified plaque resist the balloon dilatation, and this is one of the reasons why we start to think about stent to avoid an acute recoiling dissection because hold back the intimal flap. Cases with, again, calcified or complex lesions that we finally dilate, but the result is bad related to a residual dissection and the recoiling resistant after prolonging PTI or DCB. So in this type of complex lesions, as I said before, in most of the cases, we will finally need stent and an scaffold. But stent can be another interesting combination with the DCB because, we have a DES, but we cannot implant DES in every patient or in every case, or we could just starting to think about to avoid stent, to leave nothing behind. And after, as I said before, after DCB, we could realize that we finally need the stent and scaffold. And in that cases, we will for sure use a not drug-eluting stent, but a standard nitrogen stent. So dedicated stent to tackle the SFA lesion, for sure, this is what we need today. And in most of the cases, what I can say is that we already have it, a combination of multiple devices. But properly, what we need is an accurate deployment stent. As everyone said, in some cases, Supera can be very tricky and complex if we do not realize, if we do not achieve a good vessel preparation. For sure, flexibility, multidirectional flexibility. The previous speaker had been talking about the cuff, the radial resistant force, and the crusher resistance. And another interesting topic or thing is that the low profile of stent. So low profile and accuracy start to be something very interesting and necessary today. Elongation and compression can impact the patency. It was clearly explained during the previous presentation, and for sure everyone realized that if you finally do not achieve enough space, the stent remains compressed and it's elongate, and all the force, the resistant crush and the external radial resistant compression can be for sure modified. The multidirectional flexibility, it's something very, very interesting and necessary because everyone knows the multiple torsion, flexion, extension, and compression, external compression that SFA and POP receive in every movement. So the thinner struts may provide significant advantages in that multidirectional flexibility. The cuff As the previous speaker said, it's essential to have a good balance between not too much and not too low cough. So it's important to use the proper stent that manage the cough or obtain the proper cough to do not improve the result without create too much intimal hyperplasia. And finally, the less invasive, the low profile and the full French compatibility devices, because we can use this device for an alternative site, lower compression time if we have a full French access in the common femoral when we work in most of the cases in an antegrade fashion. It allows us to compress less time or to have a lower risk of complications, access complication, can reduce the contrast load, cost saving, because we can think about to do an office-based treatment, and it is safe and effective as the 6 French device. In fact, the 4 French compatibility allow us to obtain a almost 50% smaller access compared to the 6 French compatible devices. The efficacy of the 4 French pulsar proven in a wide range of lesions, because we know that this stent performs pretty well in short or medial lesions, as well in long lesions, in popliteal artery, in dissections, in occlusion, in calcified lesions, and it performed pretty well in a combination with the DCB. In fact, we have a good match for DCB, and we have some interesting data that we can see here now at the combination of Vassil looks and the Pulsar 18T3 with a very nice result at 1 year in terms of primary patency and freedom from TLR. But let me pass to the practice experience. This is a case. This is a 65 years old man with diabetes, dyslipidemia, hypertension, carotid artery disease, and previous stroke, bilateral peripheral arterial disease, previous target limb revascularization 2 months before. Not good result because the patient is back still in a Rutherford 6 class. The Y5 class is very complex, 332. Second, fourth, and fifth toe gangrene of the last foot. So the previous treatment was not so useful for the patient. What I did was an antegrade access in the common femoral and deploy a short sheath. This is a CO2 Enzo, this is my standard of practice, that allowed me to see a diffuse disease SFA with a proximal stenosis, so almost close to the bifurcation, acceptable flow distally and in the popliteal artery, very nice flow, still stenosis or diseased artery in the distal SFA, and below the knee compromisation with occlusion of anterior tibial and very thin posterior tibial, calcified posterior tibial and peroneal artery. The flow in the foot was not so poor, but not the best, because we were able to identify the median plantar artery, the dorsalis pedis, and the lateral plantar artery with a couple of stenosis. So the crossing in the SFA was very easy because it was a simple lesion. With a full French Bernstein type 2 and a V18 guide wire, I approached the anterior tibial. As you can see, some difficulties, but finally managed between the luminal and subintimal to reach the distal lumen, but never re-enter. So I leave the wire in place, I shift for a pedal plantar loop technique, cross the posterior tibial, the lateral plantar artery, and finally reach the arch. And I realized that even the arch was diseased. So it was a clear case of SAD, small artery disease. The difficulties to engage the arch with the O14 guide wire and to cross the arch, and finally reach the dorsalis pedis and was able to do a retrograde revascularization of the distal dorsalis pedis and the distal anterior tibial. I needed to predilate a bit to remove resistance and finally be able to push up the retrograde guide wire and to re-enter in the anterior tibial. At that time, everything started to be more easy because I was able to predilate the distal anterior tibial and finally changing the guide wire, I was able to re-enter in the dorsalis pedis. Final dilatation of the dorsalis pedis, the arch, and finally fully dilatation of the anterior tibial, as well lateral plantar that was fully diseased, and posterior tibial that was also fully diseased. And well, still need to treat the SFA and the POP. Multiple lesions in the distal SFA as well in the P1, P2 segment. So long dilatation, long inflation at 5 and at 6 millimeter. And this was the result. Some residual plaques that even if it were not limiting the flow, for sure were reducing the lumen. So the first pulsar T3, look, the video is for sure accelerated, but no any problem to deploy the stent. Very easy, very fast. The precision of this stent is quite incredible. You put the stent in the place you want, and you are very ready to deploy the stent in that place. There is no any jumping, no any movement, and even in the popliteal artery. And as the previous speaker said, always check in the flexion knee. Well, this is the flexion knee. Look how the pulsar perform in the flexion knee. Perfect, no any compromisation, no any entrapment, no any kink, and this was the below the knee result with complete tibials with direct blood flow from anterior and posterior tibial artery and with a complete below the ankle revascularization. Look, the final check with CO2, direct blood flow in the anterior and posterior with direct blood flow for dorsalis pedis and for the lateral plantar and to the arch. So it was a complete SFA, popliteal artery, and below the knee, below the ankle revascularization. But let's move forward for a quite different case. This is not so young. It's an 82 years old female with diabetes, dyslipidemia, hypertension, Rutherford 5, Wi-Fi class 131, TCPO2 low, and the use in the heel and the first and fourth toe of the right foot. Again, antegrade access in the common femoral, flash occlusion of the SFA, and look, you can pretty well see the calcium. So big amount of calcium, calcified wall of the artery, and long occlusion of the SFA. So a little bit more complex lesion compared to the previous case. Popliteal artery with flow, below the knee compromisation with flow from what we can understand with CO2 in the peroneal and the posterior tibial, but a little bit poor flow in the foot because seems to have only the median plantar artery. So very poor the images at that level. So look, flash occlusion, antegrade fashion, CTO guide wire, full French catheter, and even though trying to stay in the lumen, it was impossible. It is clear a subintimal progression of the proximal part of the SFA because the guide wire was going around the arterial wall. But finally, in some way, I was able to re-enter in this occluded vessel because look, now the guide wire is going straight and is in the middle of the calcium. So that was fantastic because for itself, the guide wire found again the lumen, the through lumen, and I was able with this full French Bernstein type 2 super catheter and this CTO guide wire, I was able to finally continue in the lumen and re-enter. So probably the proximal cap was so hard, but finally in the distal part of the SFA, the cap or the chronic occlusion was a little bit more soft, and I was able to penetrate to arrive till the popliteal artery, pre-dilate with 4 millimeter balloon, engage the anterior tibial to leave the guide wire in a no complex place, and finally retrieving the antegrade sheath, I was able to open properly the SFA with the 4 and with the 5 millimeter balloon. And look what happened. The place in which I was in the lumen, the result was acceptable. The place I was subintimal, there was a dissection, very bad dissection. But again, guys, I invite you to think about antegrade fashion in the common femoral in a flash occlusion. So dilate at 6 millimeter at the proximal part of the SFA, but when we think about to deploy stent there, we have a lot of risk, not only to cover the profunda, but to go inside the sheath or out of the axis. So let me say that the only one stent I use in that cases is the pulsar, because look, the stent is less than 5 millimeters close to the axis, and the time you present the stent there, you are able to put the stent there. In fact, the stent was precisely open, covering the ostium of the SFA and not going out of the axis. It was impressive. It was perfectly precise. After this, I post-dilate a bit to be sure to be able to engage the stent with the sheath without damage the proximal edge of the stent, post-dilate all the stent in the way to obtain a good position, do the final angioplasty of anterior tibial and dorsalis pedis, because this time the anterior tibial and dorsalis pedis was completely recanalized, and I was able to also re-enter in the arch. So did the final dilatation in the foot and in the anterior tibial in the way to improve as much as possible the perfusion of this foot and the toes. Remember, there was a lesion in the first, fourth, and in the heel. And finally, with an 014 guide wire, reach also the arch, as usually trying to improve as much as possible. Also the plantar flow, taking in consideration that the lateral plantar was occluded, but the posterior tibial artery was patent. So doing this type of retrograde recanalization can help a bit. And this was the result, with direct blood flow for anterior, peroneal, and posterior, some short stenosis in the TP trunk that was finally treated, and the result for the foot with direct blood flow in the dorsal circulation for the toes and in the plantar circulation from the median plantar artery, improving the flow for the calcaneal area. But another important thing to discuss is how or when we need stream or complex access. So again, very diseased patient, let me move forward very fast. Don't want to consume too much time. Iliac lesion, so I decided to go retrogradely and a crossover fashion. This is something that I don't like too much when I need to arrive in the foot, but the problem starts here. Very bad angle, very bad aorta bifurcation, very complex crossover. So I finally was able to do this crossover, changing a couple of catheters and using soft terumo wire that finally allowed me to arrive there. Previous groin surgery, so leave the catheter there, do the angio, and well, the SFA was again fully occluded. Not clear if it was occluded from the surgical point of view or if it was previously occluded, but so difficult to engage it. Good popliteal artery, occlusion of the anterior tibial, but seems to have two distal runoff vessels with posterior tibial and peroneal. Quite poor flow from the foot. Look, after I was back to try to engage and to use the crossover, I lose everything. And for me, it was quite impossible to pass there with the sheath, even with the Fortress full French sheath, because I was never able to deploy in the proper way the guide wire again. Probably the previously used devices were not more functioning pretty well. So I decided to leave this axis and to do everything from a distal axis. So what I did was to, under ultrasound, puncture the anterior tibial artery that was occluded. So I punctured an occluded vessel, put a 4 French sheath, went up with a V18 guide wire, changed the V18 for another guide wire, and was able to re-enter in the common femoral, dilate at 4 and at 5 and finally at 6 all the SFA. You will see that multiple times I will be going up with the catheter. This is an Avicross to check the result. No problem with profunda. Profunda was there. Acceptable flow in the SFA, but still some recoilings, not the proper vessel open. So what I did was decide to again stent it using pulsar, but using pulsar from the anterior tibial. This is something that is pretty well to do, very easy. Precise retrograde reverse stent deployment, starting from the ostium and going down in the proximal part of the SFA till the median and the distal part of the SFA. This is very interesting because having a full French profile compatible devices is very nice and very easy to manage a CLI patient from the distal axis without any problem, without any risk to have access complication. I finished with the second pulsar T3, 1 centimeter, a little bit less of 1 centimeter overlap, and finally going down from the SFA into the proximal popliteal artery. I did the last check after this, and I realized that there was still recoiling in the P1, P2 segment, so I decided to finally put the third pulsar stent. You will see now, this was the first check with a very good result in the proximal SFA, good result in the median part of the SFA, but still recoiling in the popliteal artery. So put the last pulsar and did the check from the full French sheath in anterior tibial that allowed me to understand that everything was functioning well. So I stopped the case at that point and managed this full French access with external compression. So the take-home message, the full French access is feasible, safe, and effective, and allow us to do it even from some extreme places or extreme access like this anterior tibial. So have a full French compatible devices is something interesting and allow us to think about treatment algorithms compatible with the full French, select the right materials, as we have been discussing right now, the sheath, the guide wires, catheter, balloons, and stent. Offer a tailored approach to every individual patient, because even if you have a plan, but you need to change it during the procedure with the full French compatible devices, you can go clearly fast without many problems. And well, about the Pulsar T3, very precise, no kinking, easy to use, compatible full French. Let me say that I really like this multiple flexion stent with the thinner struts that allow us to be very precise in the ostium of the SFA, even working in an antegrade fashion. And for sure, well, thinking about vessel prep before stent, I think that we are in the proper way, in the correct way, thinking to rethink vessel preparation and being more aggressive and progressive, and still continues working in the proper way to obtain a better lumen gain. For sure, post-dilatation in most of the cases is essential, but still some doubts about that. I think in the future, we will need to manage more and more the vessel prep to, in some way, even allow, it will allow us to even avoid the stent post-dilatation. And with this, I finish. Thank you so much for your attention.
It's at 2 o'clock. At 2 o'clock. This is...
Thank you, Dr. Palena. Some questions? What do you think about, I have a question, what do you think about drug-coated balloons for below the knee?
I think these are a very nice option. I think in most of the cases, this is the only one option we have, because atherectomy is quite complex. We today have a good device for atherectomy, that is the orbital atherectomy, but for the others atherectomy devices, we have some difficulties to arrive in below the knee and distal, more distal. The same with the stent. When we are going to treat long tibial lesions, it's difficult to think about to treat all of this long occlusion with the stent. So I think DCB below the knee are a very good tool. I believe in that. I use it in most of the cases.
Thank you.
Can I ask something else? Do you always perform balloon angioplasty of the arch, even if it is patent and you use it as a collateral pathway? And what are the sizes of the balloons you use usually?
Well, the first thing, never touch what is healthy. In many cases, I use the arch like a crossing strategy, crossing from anterior to posterior or vice versa. But in cases in which the arch is healthy, I never dilate the arch. When I need to dilate the arch, the diameter I use for the arch is between 2 and 2.5 millimeters.
Thank you.
Okay. Thank you. Thank you for the wonderful presentation.
Thank you, guys. Have a nice congress.